good about this. Okay. We ready?
Action.
All right. Hey, Paul.
Hi.
Thank you so much for being so generous and kind with your time. I loved doing the book signing today for your daughter. I feel like it's a culmination of a lot of years of, you bringing that into the world, and now that she's here, showing her off and introducing her to all my friends.
Well, thank you. It's a pleasure to bring her here and have her be amongst people who are so clever and authentic and committed to behavioral health care and providing the highest quality of behavioral health care possible for everybody.
Yeah. I know that, having read your book, I know what brought it into the world, but for people who haven't yet, would you mind just kind of talking about how that went from glimmer in your mind's eye to out into the world with all of your 4.7 star reviews?
Oh, well, thank you. It was a long process. The books, it was a labor of love for sure. I had always wanted to write a book. In my prior life, I was a lawyer. And so I remember the partners calling me into their office and saying, "You don't seem very happy here. What would you really like to be doing?" And I immediately responded, "I'd like to write a self-help book." And they looked at me and said, "Well, we think you're in the wrong place. You probably need to go somewhere else." And they were right. I did. So I left the practice of law and went into psychology. And then there's just some observations that I made in life. Working in the realm of philanthropy and for social justice organizations, I observed how people of wealth were being talked about and treated differently. And I knew there was something there. And so I'd been thinking about it a long time and really got some education, did a master's and then a PhD, and started lecturing about this particular topic around the world, and wrote the book, put the book away. Some agents were interested in it, but really didn't want to do it from a clinical standpoint. And then Hazelden came to me and said, "We would like for you to write the book about your work, and you can write it however you wanted to write it," but we were really focused on having it out there with clinical integrity.
Yeah.
And so I really wanted the work to be grounded in empirically based science and be grounded in clinical integrity.
Yep. And I think that's what makes it so valuable. I think, like you, I've worked with the same population. We laughed the first time we ever met about how you treated the parents of the people that I was treating.
Right.
Same generation, just different population.
Right.
Me, 12 to 25, and you were dealing with their parents, and it was like a light bulb went on, and we were like looking into each other's sphere, because I'm not dealing with what you're dealing with, but I'm dealing with the fallout.
Right.
And if the people that you're dealing with don't get well, I'm dealing with the fallout of what to do with the not wellness in their children.
Right.
And I agree with you. I think there's such a stigma about wealth in general. And you said it earlier in the book signing. You said people imagine if you have unlimited wealth that you have unlimited happiness. And I certainly in my clinical practice have found that that's not at all true.
Right.
I would love your thoughts on that.
Well, I think it's absolutely true. And part of one of the light bulbs that went off for me in this work when I was working with a family, and there was a daughter who had a behavioral health issue, and it wasn't just isolated to her, that she was existing in this system, in this very wealthy system. And while I had been taught that money solves all problems, whatever problems you have, I saw that in this particular family that the wealth was actually really creating more problems, different problems. In the poverty has a set of problems, and wealth has a set of problems too. And we always think that it's just the poverty that has the problems, but there are challenges associated with an identity of wealth and having wealth, because that tends to eclipse a person's humanness. And so I noticed in that relationship with the parents in particular that there was this disconnect, and the way that the disconnect was trying to be healed was Dad's currency, literally and figuratively, was to throw money at the problem.
Sure.
And it wasn't what the daughter needed. It wasn't what the family needed to really heal from these behavioral health and these family problems in the family.
Yeah. I remember when I first started working with this population, some of the things that, some of the problems were things I wouldn't have thought of.
Right.
And I feel like your book, I had the same impression when I read the work of Patrick Carnes. He did a ton of data and research on things I wouldn't have thought of.
Right.
And so certain things I feel like, just the general population, one of the things I recall was this child on their 18th birthday inherited $50 million and had no idea that $50 million was coming their way, and then felt undeserving and also felt like imposter syndrome, and then also felt the third thing they said was, I don't want people to know.
Right.
I don't want anybody to know that I have this money, because if they know that I have this money, maybe they won't like me for me anymore.
That's
right?
Right.
What are some things you can think of that are unique to this population that we need to have more empathy around?
Well, as clinicians, I think, I really need to be clear about my work and the focus of my work. And I work in establishing an identity of wealth amongst other identities deserving cultural humility in the provision of behavioral health care. It's very narrow. And so if we know that we're dealing with a minority population, which we are, we talk about them all the time, the top 10%, the top 1%, then we know, just like other minorities, there are cultural markers of this population. And through my research and through my work, I've identified three. The first is isolation, that people of wealth tend to live much more isolated lives because they don't have to engage in the currency of life like middle class or lower socioeconomic people do. The second is suspicion of outsiders, that human beings are tribal and we organize against common interests and against common foes. And so people of wealth, just like other cultural identity groups, tend to congregate together and live in the same neighborhoods, drive the same cars, have the same cultural markers. And the third is unique to this population, and that's the construct of hyperagency, which is the capacity to control your life to avoid discomfort, which relates to the first, doesn't it? Because you don't have to go and wait in the queue at the grocery store. You don't have to queue up to do really anything. And so we know that there are these distinct cultural markers of this population. From a clinical standpoint, if we know that, then like other cultural groups who are deserving of cultural humility and cultural competency in the provision of behavioral health care, then we need to address our clinical services towards meeting these people where they are and not expecting them to be at a different place, so that we can establish a reparative therapeutic alliance with them, so that we can address them in the wholeness of their being and not have them hide a bit of who they are.
Yeah, I feel like that's helpful for so many. And I think also just the identification of the prejudice is helpful.
Right.
I mean, I will never forget the first time I went to the Museum of Tolerance. And, it was like open the door, pull this handle, and you really recognize everyone has prejudice. Everybody has bias. And the idea that there's bias against wealth, I think we're at a time in society where there's such a split between people who have wealth and people who don't.
It's not getting better, by the way.
It's
either.
not getting better.
No.
And I feel like the feelings about that and toward that are so extreme that it becomes even more difficult for the population I treat, the younger population, who feels apologetic that they come from wealth when they really have absolutely no control over the fact that that's where they came from, just like children of poverty don't.
That's exactly right. And I think one of the things that's helpful is taking this out of this paradigm of better than less than, more deserving, less deserving. Like people who live in diminished power in our society are more deserving of clinically excellent, culturally competent behavioral health care. I think everyone on every point of the socioeconomic spectrum deserves the best quality clinical care and the most competently respectful, the most culturally respectful care that they can possibly provide. And that shouldn't have an economic threshold.
Right.
It should be to everybody. And so taking it out of this paradigm and recognizing that we exist in this paradigm of better than more deserving, less deserving. It doesn't, in terms of behavioral health care and providing good services, that's not really relevant, isn't it? If you're a human being and you're suffering, you deserve the best quality care that can be provided to you, regardless of who you are, whether you're rich, poor, white, black, gay, straight, Christian, Jew, Muslim. I mean, it goes on.
Agreed. I remember, and this was nuanced because I don't play NFL football, right? I'm the outsider, but I'm often in the inner circle where I'm the only outsider in the room who doesn't have that skill and hasn't done that thing. And I remember talking about healthcare And it was, I don't remember if we were talking about behavioral health care or real, orthopedic care. But this NFL player said, "You don't understand. I've never been in a waiting room in my life."
Right.
And I was like, "What?" And he said, "Yeah. I mean, the trainers and the orthopods, they come to us. Like, we
Right.
don't sit in a waiting room for any purpose." And he said, "I didn't do that until I retired." And for this man, retirement was in his 30s for the thing that he had prepared for his whole life.
Right.
And, hey, how long have you wanted to do the thing? Ever since I was this tall. And okay, now and it was under 35, right? But it was like, hey, okay, I'm 35 and I'm retired. And sort of that, even the use of the term retired for somebody who's so young,
Right.
it doesn't matter whether you're retired from professional sports in which you've been very well remunerated, or if you don't have to work. Like
Right.
I recall somebody saying, "You're so lucky you had to figure out what to do with your life."
Mm.
And I hadn't thought of that paradigm shift of like families wherein the clinical work is around what is the expectation for this child.
Right.
And the family would say, "Well, what do you mean?" And, "Well, is it expected that they do charitable work? If so, like how much and how many hours a week do they need to spend doing it? Is it that they need to be up at a certain hour? Do they need to spend 8 hours of productive work? What are the expectations?"
Right.
You're really clear they're not meeting them, but
Right.
what are they?
Right.
And that's profound, to shoot at a family system where for multiple generations nobody has to generate income.
Right.
And so then you have to come up with a set of norms that's unique and different from people who work for purpose of gaining income.
Right. And I always tell parents, don't tell your kids they don't have to work and they should never worry about money, because they do have to work and they do have to worry about money. So do they have to work to make money? Maybe not, but they need a primary identity that is not their identity as a person of wealth. Because if your primary identity in the world is that you're a rich person, there's going to be some major bumps along the road. So use the wealth to support you finding another identity
Right.
in the world.
Yeah. You said it before. You said, the Rogerian approach of like, it's the relationship that heals, right? And the idea of someone who's comes from a hyper affluent background trusting another human being enough to tell that human their story and their
Right.
hurts and where they are, like where are you and how do I help you get to a life you can be proud of?
Right.
That's always where I come in. Something's not working, and how is it that I can help to steer you towards something you can be proud of? What would make you proud?
Right.
And the idea of that engagement, how would you tell clinicians who may not understand or haven't worked with this population enough to know it's really about finding the value in each human being?
That's right.
How do you do that if the person sitting in the chair isn't in that same class group?
It's a bit of a challenge. First of all, clinicians have not been trained to deal with this particular population.
Right.
And there's an extraordinary amount of what's called transference, countertransference
Right.
that happens in the therapeutic relationship. So the patient is projecting things onto you, and then you in turn are projecting things back onto the patient. So understanding this as a cultural identity that deserves cultural humility, and cultural humility is cultivating curiosity. Like, I could never know what it means to be you, so a woman
Right.
in our society. But by cultivating deep curiosity and openness to your experience without shutting it down or without canceling it is critically important. And I think clinicians need to be able to do that. And they also need to understand that we're human. And we're going to have a reaction. So if an Oscar-winning actor comes and sits down in front of you for therapy, your countertransference reaction is you are going to see them as an Oscar-winning actor. So let's not pretend that it's not there. Let's make sure that you have a process to name it, to own it, and process it in supervision or with your colleagues. Because if you don't, it's going to come out and bite you, because this particular population is so used to being objectified, and everyone is coming at them constantly for everything from, can you pay my rent, to can you put my kids through, I mean, let's buy this, whatever. It's constant. So their antennae is very developed in terms of feeling you, like, why are you here? Are you safe?
Mm-hmm.
Are you safe enough for me to come forward with my identity as a person of wealth, and that you won't take advantage of that?
Sure.
That you won't, all of your fees are all of a sudden $250, now your fees are going to be $550.
Mm.
And so I think being able to own that reality, that celebrity and wealth are different. They're not better. Again, it's not a better than, less than, more deserving, less deserving. It's just different. Just like when I work with a Muslim family, and I need to be culturally sensitive to what it means to be a Muslim firstborn son. And that means something.
Sure.
And so this is really no different from that.
I think I would love to know from your perspective, because we deal with opposite sides of the same coin, right? I would love to know how it is that you, when you recognize that a person of infinite wealth needs treatment, for example, a performing artist that I had worked with said, look, I never had a rock bottom. Like the idea of rock bottom, there's no bottom if you still have infinite wealth.
Right.
I'm not destitute. I still have money. And so this person's rock bottom was law enforcement related, right? And this person said, like, hey, look, my rock bottom was like I sideswiped a parked car and I was absolutely certain I'd killed somebody inside, right? And so I would love to hear about that, like how it is, because it's very different than the traditional intervention that happens with middle class families or people who need an income, where it's like, you are going to lose your job, right? What do they stand to lose?
Right. So there are two considerations when you're trying to get somebody into treatment. The first is internal motivation to change, and the second is external motivation to change. We want the patient to be as internally motivated as possible, because the outcomes are much better. If you don't have that, then you start to use external motivations, like losing jobs or losing relationships or things like that. And so I think that this is where the value of the therapeutic alliance comes in. So this is where the interrelational aspect of it is the work. So you can sit with the patient and have an honest dialogue about values, about what's important, about the things that are happening in their life, and in a way that isn't judgmental, but just allows them to space to have these conversations, and in the witness of another person who is really deeply trying to understand their world. And I think the most value that I provide in a therapeutic relationship is asking questions. It's really about figuring out what they're saying and then ask questions that can draw out where there are inconsistencies and where there's stuckness in their life. And I think that's the process. I also believe the value of talk therapy is in the narrative that's created, because we live lives, and particularly of this particular client population, in hypermobility, tend to live itinerant lives. So it's raining in Newport Beach, so we're going to go to the desert, or it's cold in New York, I'm going to go to Miami. And so there's constant moving around, and through that process, they lack community, they lack society, and having another human being who they can sit with and create a narrative as to their life and what's happening, and so it enables them to see it more clearly. And through that clarity, hopefully what we've done is we've turned up the internal motivation to change, and that's the most important outcome for successful treatment. That when people are forced into treatment, the outcomes are pretty dismal. They're not great. But when somebody's really motivated to change and they feel a reason to change, that's more helpful to outcomes for that.
Yeah, I get the petrified parent who says, I have to force this child.
Right.
Because if I don't force the child in the opioid
Yes,
era,
well, sometimes it's
they might,
right.
might lose the
Right.
child, right? And so for me, it's about what is a child, and by that I mean someone under 25, willing to trade off in order to, what do you love enough, or what do you want enough that you're willing to trade this salve that has made you feel
Right.
nothing or safe or something for something that you value enough. And
Right.
then the dialogue, just like you said, is in the asking of questions. And one client I'll never forget said, well, I want to go to school in New York. I really want to go to the Parsons School, but I know that's not allowed. And I was like, what do you mean it's not allowed? Well, that's not that's not going to be acceptable to my dad. And
Right.
hey, I'm a thinking person, and being artistic isn't allowed.
Right.
And meanwhile, I'm holding the story of like, this man's terrified that you're going to die like every single weekend.
Right.
He holds his breath. And I'm pretty sure that I could negotiate on your behalf that if you go to treatment and you stay in treatment X period of time, that at the conclusion of that, at the end, you
Yeah,
could go
brilliant.
to Parsons.
Brilliant.
Right? But it's about figuring out what is it that you want and or love enough to do something that you're willing to go through pain for.
Right.
Because treatment is painful.
Right. And it's cultivating that curiosity, right? That respects the cultural boundaries of that particular family, right?
Yeah.
Because dad probably wanted her to go to an Ivy or an elite college. And so recognizing that that is in that particular family system, that's really important. And so we can't ignore that. And so you were able to hone in on that as being something that's really important to this family and their legacy and their culture, and then figure out a way to motivate her through that. So that's exactly how it's done.
Yeah.
Yeah.
Yeah. Speaking of how treatment is painful, how many times have you been to a treatment center where they'll say, I need help. This person wants to leave. And
Right.
and I'm like, well, yeah, they say the food stinks. And, and it's like, and the therapist and the treatment team and the treatment owner thinks, well, yeah, it's garbage food in treatment is to be expected.
Right.
Well, no, not from somebody who has a
Right.
personal chef, right? Who might
Right.
make personal meals for each member of the
Right.
family, right? And so the idea of if you are a treatment center and you service a hyper affluent client, there are certain nuances that you have to be aware of. What are some of those?
So going back to the cultural markers of this population, isolation, suspicion, outsiders, hyperagency, if you look at all those cultural markers and you think about how residential treatment's been historically delivered, cuts against every single one of those, pushes against every single one of those cultural
Right.
markers.
Right.
So you look at what's something kind of out of the psychodynamic that talks about egosyntonic. There's egosyntonic and egodystonic. So the environment that this patient is going into is egodystonic. It's inconsistent with her identity in the world. So you want to provide the patient with an environment that's egosyntonic, that's consistent with her identity in the world, so that she will be more apt to identify in as opposed to identifying out. Because as you noted so well, that going into a residential treatment community, giving up your primary coping mechanism, the thing that you think makes your life works brilliantly until it doesn't, is super painful and super challenging. And so it's helpful if you are in an environment that mirrors back your perception of yourself in the world. Is this necessary for all particular cases? None of this is carte blanche. None of this is like, one size fits all. It all depends upon the client. There are some clients who I wouldn't want to go to $100,000 a month treatment facility because it just feeds into a lot of some of their pathology. But there are other clients who, if you've built and sold a company for 100 million euros, then you're not going to go scrub toilets, or you're not going to go share a room and sleep on bad sheets. You want to be in a community where you see yourself mirrored and you're with other patients who are successful and clever, because one of the major values of residential treatment is something that's called the psychosocial component of treatment. And so if you're a clinician who's going to come outside of your social class, who may not have gone to an Ivy, if you've gone to an Ivy, or may have a master's degree, if best, right? It tells you, I think you should do X, Y, and Z. You're like, oh, what do you know? But if you go and you're having dinner that night in the residence and another CEO says, oh, I listened to whatever he said, the clinician, and you know what? He was spot on. I started doing CBT treatment, and it's been really effective. Now, all of a sudden, this opens up something in that patient where that patient's like, oh, okay, yeah, so maybe this is something that I should try. It's that peer-to-peer aspect of treatment, which is critically important.
Mm-hmm. Yeah, I heard it said well by a treatment center executive director who said, I listened to what the client said, and they said the beds were lumpy. I got better beds.
Yeah.
If they said the pillows are trash, I got down pillows. When they said I don't like the sheets, and this gentleman said, I just took away the noise.
Yeah.
And I thought, I don't want the noise to be the reason that you're going to leave. Right. And the whole idea, I mean, I think you have amassed the most data on what does it look like and what does it need to feel like to come to a place of healing for people in this population.
The challenge of that, the flip side is, though, training clinicians to be able to see that patient not as a difficult, entitled, narcissistic, rich person.
Right.
Because if you don't live in that world, you don't understand. You look at it with hostility, then that patient becomes a difficult patient. And I write about this in Fragile Power in terms of that these patients who who are demanding because they're used to being served. You can't expect them. I mean, you can expect them to come in and treatment. It's not going to work. They're going to leave. So the goal of treatment is to get a patient, to admit, and then get the patient to stay so that they can get the medicine that they need. If they leave, they're not going to get the medicine. This is what I talk about in terms of training clinicians to work with this population as a cultural competency, because then you have the therapeutic alliance where the medicine can be delivered, right? It's like no different from medicine, from vaccines. If you want a patient to get a good vaccine, you need to have good needles.
Yeah. And
you need to have needles that do the job that they can do. So the same thing with clinicians, that a lot of these treatment centers, you've been around, we've been around for a while. And so I think what happened was the treatment industry has gone through significant changes over the last 20 years, 25 years, and it's changed radically. And so what happened was managed care came in and profit margins were squeezed. And so treatment centers saw, we can open up executive level treatment centers and charge private pay fees and charge 100,000 euros, $100,000 a month for this. It provides an egocentric environment for them, right? So you provide a holding environment for the patient, but then then you need the medicine. Like you need the clinical staff who are able to sort of recognize this population as a culturally distinct group of human beings who need to be met in where they are and not expect them to be people who they're not. They're just not.
Right.
They're just not. If you haven't taken the subway in 20 years, your car service, chances are you're probably not going to take the subway, again. And nor should you, really, honestly, if you don't have to.
Right. I think de facto I have been asked to train some clinicians after they've messed it up badly, right? And so it would be incredible if it were a proactive invitation of, we would really like to learn this cultural competency. Right. And I think there are a few treatment centers under construction now that are funded by family offices who are in this place and are very committed to
quality care.
Yes, because lives have been lost with where it doesn't exist. Right. And so you're exactly right. If people leave treatment prematurely, bad things happen. I'm a clinician who likes data, and you love data too.
Love it.
Numbers make me feel safe, right? And I need a frame. So the idea of like, hey, okay, what is the thing that's going to get you out of here and into long-term sobriety with the least amount of times of having to do this repetitive thing that's painful? For me, it never made sense. There was always like, if there is a reason why you are not sober, there has to be a barrier or an impediment, or there, like, let's analyze what the issue is. And I remember talking to a particular very powerful man who said, you're the first person who's presented this in a way that makes sense. Because my sense is always science. It's always like, I don't care. In addiction specifically, you're always going to find somebody to agree with you that you're not an alcoholic, you're not an addict, you don't have process addiction, you're not a sex addict, something, right? And so the idea of like, well, Uncle Joe thinks I've got a problem, but my mom doesn't. And well, and what about you? Do you think you have a problem? I don't know. I don't know if I have a problem. And to be able to say, well, here's what your brain says.
Right, it's brilliant.
Right, the scientific insertion of technology in hyperaffluent populations, they expect the latest and greatest, and the numbers have been abysmal for decades. I mean, since we started tracking the numbers, which was just the 1960s, I don't think we have a lot of data of what does addiction treatment look like prior to that, because I don't think we even identified it as such. Right? So it's just been a pretty short period of time where we've tracked what do the numbers look like, but they're static. And the idea of like, and they're abysmal. It's sort of like, hey, why don't you come do this thing that's going to be painful, and there's a 75% chance it will not work. I don't know who's signing up for that.
No.
And
it's going to cost you a lot of money.
And it's going to cost you a lot of money and be painful.
And you're going to have to leave your life, which is pretty comfortable, independent of the addiction. So I think the science that you're doing is brilliant, and showing these patients the data, the empirical science. And that's why I admire your work so well. My work is the art. I view my work as like an empirically based work delivered through an art form.
That's it.
Relationally. Because the art of the therapeutic alliance of getting the patient to trust the data, and more than that, to trust you. I mean, the patient has to trust you to deliver the data. Because if the patient doesn't trust you, then you have the best data in the world. And that requires you, Karen, to show up as you do, with care and concern and authenticity and integrity. And so that's where the value proposition comes in. For me, anyhow. I mean, and for you, I think that the art of this, I feel that the work that I do, I look at myself as an artisan that works with empirically driven data.
I would like to shift and talk about narcissism like you do in your book. And I feel like narcissism is in the zeitgeist now. It's everywhere. I mean, it's like it's overdone and overused. And just like, the youth of America overuses OCD, right? Narcissism is sort of like, I just am a realist, and I go like, most powerful people,
of course,
are narcissists,
of course,
right? And the idea that, like, I mean, I say to my physician husband, like, there's not really a doctor out there that doesn't have some degree of narcissism. You have to. You're holding somebody's life in your hands, right?
And to get through the training.
All of it, all the things, right? But the idea of like narcissism not being a bad word, and narcissism being a tank that we can all swim in comfortably and know what the strokes are. Talk about that.
Yeah, I mean, narcissism is an adaptive personality disorder. It started by a person was somebody whose love and care they needed desperately betrayed them. Big B, little b, it doesn't matter. This is where the biophysics come in, right? Because your central nervous system is different from mine. So a betrayal for you may not be a betrayal for me. So there was a betrayal. So somebody whose love and care and protection they needed betrayed them. The message that they learn, because they're super clever and super smart, is that I'm never going to put myself in that position again.
That's right.
I'm never going to be vulnerable with another human being. What I'm going to do is invest in the things that are tangible. I'm going to get external success. I'm going to make as much money as I can. I'm going to be on the top of the heap because that's where it's safe. So it's a profoundly adaptive personality disorder. It gets skewed, though, like any personality disorder or anything in life, right? It's not this binary of good narcissism and bad, but you do, but there's this whole range within there. And so there's healthy narcissism, which is kind of a version of self-esteem.
Yeah.
Like, I'm not going to put myself in situations where I'm going to get my feelings
Mm-hmm.
hurt. I'm going to learn because
Yeah.
I'm clever and smart.
Yeah.
And then the other side of that, though, is malignant narcissism,
Right.
which tends to, because we see examples of it, we're seeing examples of it out in the public domain, where it's a combination of narcissistic personality disorder, psychopathology, and Machiavellian tendencies. And those are highly destructive to relationships.
Sure.
And if you are interested in human relationships, then skewing on that side of the narcissistic spectrum is not beneficial. But it exists as a spectrum, and there are really good aspects of narcissistic people have done amazing things in our world.
Of course.
We wouldn't have the inventions, we wouldn't have the medicine, we wouldn't have the science, we wouldn't have the literature, we wouldn't have the theater, we wouldn't have the art if this world was void of narcissism.
Right.
I think we could do a little less with malignant narcissism.
Agreed.
At the same time, let's not just sort of ipso facto say if you have narcissistic personality traits, then you are evil and mean and malicious. This is getting into what we call faulty generalizations, where we're generalizing the whole for just a few bad eggs, really.
Totally.
Yeah.
I think there's also the blanket idea that narcissism is an incurable disease.
Right.
Right? And if you've got one, you should wash your hands of the narcissist. I was speaking to a brilliant neuroscientist who's just relocated to Portugal, and she's Oxford trained, and said, like, someone needs to write like a book to navigating narcissism.
Yeah.
Like, look, this is how you can see it through their lenses, how they can see it through your lens. The definition of narcissism in its full-blown form is an inability to have empathy for others, right? And that's because at some critical juncture, there was someone who didn't have empathy for them or see them as themselves at a critical developmental stage, right? And so what do you say about the ability to have empathy for the narcissist? Because that's often who you sit with. And I often sit with the narcissistic family system. In fact, like if you light a match under my foot and say, like, which dysfunctional family system are you best with? A narcissistic family system.
I quite like a narcissist too, honestly.
Yeah, really absolutely.
I really do. I do have empathy because I realized that the cause for it was because people were crappy to you.
That's right.
And so, like, I get it. People were crappy to me, and so, like, it doesn't feel good when people are crappy to you. And so I do have a capacity to deal with it. I think that in terms of curing, I think you can soften the edges of a narcissistic personality disorder. Again, the patient has to be motivated. Like, what's in it for them? Like, where's their Parsons? Exactly.
For sure.
Yeah.
I think also there's the desire that or the fear of the clinician, like, narcissists don't stay in treatment. And then the truth is, they do stay in treatment if you anchor them properly before you push.
Right.
And you frame it appropriately. Right? And I think that's where clinicians fail when they go, oh, this person looks and feels like a narcissist. They're not going to stay. Therefore, I'm not going to invest in the relationship.
Right.
What do you say about that?
I would say that's the clinician's narcissism. That's actually because they're afraid of the ego injury that's going to happen when the patient terminates treatment.
Yeah, that's fascinating.
Yeah.
Yeah. I think...
so it's a bit of a projection, isn't it?
Yeah. Yeah. I think I love narcissistic family systems because they're typically well-contained and well-defined.
Right.
Right? It's not the chaos of, like, a borderline family system.
Right.
Right? And so the idea of a hyper-affluent narcissist, it's sort of like... I equate it to, there's a treatment center that gives them MPI to everybody in newly in recovery. And the women ultimately come up borderline.
Yeah, sure.
76%, right?
Right.
And then I go, like, that's an inability to self-soothe, like, but you're putting this label on this person because they can't self-soothe right now because the substance they've used to do that is gone. What do you say about all of that? Like,
yeah, I think you need to be careful. I don't think that you should really be making personality diagnoses within the first week of entering a treatment center.
Right.
That's definitely not the case. I do think there's gender biases on all of these things. I think there's, like you said, women are diagnosed as borderline and men as narcissistic.
Mm.
Codependency is another feminine thing,
Mm.
right? Where
Mm.
women got a bad rap for being codependent, and that's another word. It was, the integrity with which codependency entered the clinical field is brilliant. It just changed so much in the way that we think about relationships, particularly in the field of addiction treatment. But I think now it's just a throwaway. He's a narcissist, and I'm bored, and I'm codependent. It's like, well, wait a minute. You love your family, and you want the best for them, and like, there's some cultural elements of this too. So let's have a conversation around really what codependency is, and what narcissism is in its pathological state.
Yeah.
So yeah.
What about the idea that narcissists can't really love their families or children? There's a lot of that being thrown around right now, out there.
Yeah, no. And again, they learn they love their family through a different currency. So typically what you'll have, and we've worked with these cases before, where you have parents, mother, father, who do super well, like made a lot of money because that's what they thought would provide love and care and support, protection for their children. And and so these children have grown up in this culture. So typically what I see parents who grew up in emotional and well, yeah, in emotional or financial scarcity. So they've internalized their self construct is scarcity. The lens through which their psychological schema is of scarcity. And so they go out because they don't want their kids to have to suffer like they had to suffer. So they go out and make a lot of money because they think they want to provide the kids the best of everything. Send them to the best uni, best neighborhoods, best food, everything. The kids grew up in this environment of material abundance, but maybe emotional scarcity because mom was out building a company that she subsequently took public. And so you have this disconnect. Doesn't mean mom doesn't love her kids. Sure. I don't think I've ever been involved that doesn't love her or father. It's because that they have different schemas. They have different goals and they have a definition of what love and support is. So I think that's just rubbish. Honestly.
Yeah.
Yeah.
Yeah. And I think clinicians need to hear that more often. And the statistic for how someone thinks of their own financial security within a family system is established by the time they're 9 years old.
Hmm.
Um, and I think that is profound just in terms of how parents talk to their children or about wealth or about, and an example I'll give is like, I think it was in fourth grade, and I'd moved, I was a consulting engineer and we moved a ton. And this friend said, when is payday? And I said, excuse me? And she said, yeah, payday. When your dad gets paid, when is that? And I said, I don't know. And so I went home to my English parents and said, hey, when is payday? And my mom said, I beg your pardon. Where did you hear that word? And no, that's vulgar. We never speak of money. No, what is payday? She was horrified that I had heard this somewhere,
Really?
right? And the idea of like curiosity about money, I've heard this in wealth management circles also that hey, sometimes family offices wait too late
Mm.
to tell their children or to engage their children in a cause.
Right.
And they go like, I'm not going to tell you anything about our family philanthropy or our family ideas about charitable giving until you're 25. Right. And the banks and the banking organizations and the wealth managers say that's too late.
Mm.
Start cultivating before they are 9.
Right.
Like, what do you care about? What's something that you personally care about? And does that have to fit in under the family umbrella of care? What do you say about all that?
Well, I think it's spot on. I mean, I think that this notion of, like we talked about earlier, you don't have to work and you don't have to worry about money. Not good. I think that children do need to understand the value of money. like they need to understand what money is and how it operates. Um, Kids know that they're rich. Think then that they just know, right? If you're, if you charter a yacht for spring break, chances are you're rich. And so figuring out to have conversations with your kids that are honest and age appropriate. Um, Again, but it's not really a carte blanche. So, I mean, like we have clients where children can be 25 and they just don't have the capacity to handle money because they're cognitively impaired or they're behaviorally impaired. And so, I think it's a case by case with everything. It's a case by, this is where the art of everything we do comes in. So it's a case by case basis, but I do think pretending it doesn't exist, it's not, that's not a healthy way to go about doing it too, because it's intense. Yeah. Like if, especially levels of wealth when you're getting into, I always think like, I don't know, things like, what I think like hundreds of millions, even $60 million. It's a lot of money.
Sure.
And so, when you have that, like just conceptual, how do you conceptualize it? Like, how do you conceptualize you're worth $1 billion, which everyone seems to be talking about now. Everyone seems to be a billionaire these days. I don't know. But like, how do you conceptualize having like $100 million? And like, how do you accommodate that into your identity as a person and then assimilate it into your life in a way that doesn't just blow all your circuits?
Well, and compare and contrast that if you've earned it versus
Right. Huge,
we've inherited.
huge difference.
So talk about that. I mean, the whole like imposter syndrome or the guilt of inherited wealth or the burden.
Right. Right. So there's the psychological construct of elements in that conversation are locus of control, internal locus of control, external locus of control. If I earn my money, I have a robust internal locus of control. I'd be cross if I lost my money, but I'm confident I could probably make it again. If I did it once, I could do it again. I have more sense of agency. I have more sense of responsibility for my life. Um, I don't really care if people like me because I'm rich because I mean, like I worked really hard to get rich. So,
Yeah.
so it's fine as opposed to inherited wealth or something that's not talked about. I think we need to talk about this more in the field is or spouses who marry into families of wealth, because that's a really tricky bit to negotiate. So if I've inherited my money, I really, I'm not really sure if I could survive on my own, right? I'm okay in the zoo, but probably it's going to be a challenge for me to go out in the jungle and survive. So they're not really sure of their capacity. They're not sure of their ability to survive in the world. They're not sure whether people like them for who they are or because of their identity of wealth. And this is where wealth creates such isolation. And so people just tend to associate with people in their socioeconomic class. And if you're worth $1 billion, while there seems to be a lot of them out there, there aren't really that many, right?
Right.
So your world becomes smaller and smaller and smaller. And so I think again, I think it's understanding wealth as an energetic. Wealth is something that is good to have. I also like to avoid this narrative that money is evil, like ipso facto. It's like, I think that's rubbish. Money can be used to evil purposes. Money can also be used to really amazing purposes. So I think that, again, we need to avoid these binaries about something is white belt, black and white thinking, which is like it's either good or it's either bad. It can be, it holds this potential, but yet it's how you utilize the wealth and how do you want to manifest yourself as a person of wealth in our world, and understanding that identity or wealth is just one part of a multifaceted identity. I'm sure you're aware of Kimberly Crenshaw's work on it's brilliant. Intersectionality, and says that, we are more than just singular identities on top of each other. We are multiple identities that intersect, that form a unique being in the world. And so incorporating wealth into those identities, not allowing it to eclipse the other identities. But I'm the adult son. I'm an adult Muslim son from a Middle Eastern family who comes from wealth, who is exploring a transgender identity. I mean, these are all highly relevant identities that need to be considered in the therapeutic space, right? And not allowing, not, and what's happened historically is that wealth is either denied, it's not important, doesn't matter, or it's something that's ipso facto evil and destructive. And those are just not, those are not productive conversations to have.
Yeah. What are your thoughts on wealth? I read them in your book, which is why I'm wanting you to share. Wealth as it intersects with celebrity.
I think the two are separate. I think that you can have celebrity without wealth. And that's a tricky bit too. So, and that's kind of more dangerous because here you are out in the world and you don't have the protection of wealth because wealth is a protector. Sure, it's a huge protector. And so if you are a celebrity and the world is constantly coming at you or projecting, idolizing you or demonizing, right? I mean, we split with people of wealth. And celebrities, we either love them or we hate them, and so there doesn't seem to be a middle ground. And how quickly we love to see a celebrity fall, or how, like in Britain, the royal family is like, I mean, they sell a lot of magazines, yeah, because of people's projections. We love them and we hate them, and so I think celebrity is much more dangerous than wealth, because with wealth you can hide more, sure, than you can, that's right, with celebrity. And so, walking into a restaurant or like going into a grocery store, you can't be engaged in that currency of the world. So I think it's a really tricky, very dangerous, it's so very hard to negotiate successfully.
Yeah, especially at a young age.
Young age in particular, right? Because if you achieve celebrity at a very young age, then that's where your baseline, that's where your neurophysiology gets gets kind of calibrated up to that higher level of being celebrated, being revered, being idolized.
Yeah, Jason Bateman said it really well in an interview lately where someone said, "Can you give a piece of advice to a young child star?"
Mm.
He said, "Yes, don't be a young child star."
I go into medicine.
And he said,
Right.
"No," he said, "you need to know who you are inside,
Yeah.
and who you are before you pretend to be someone else."
Yeah, well,
Right.
like,
And I felt like, wow, I love him as an actor anyway, but I thought like, wow, that was a profound piece of advice
yes,
for people who celebrity is something people seek, especially in this world of
both.
Instagram and social media and how many followers do you have and what platform and all of the things, right? And the idea of like the self-made celebrity. I mean, Justin Bieber was the first person who really
Yeah.
was discovered as a child from something he was putting out there, such an art form that he was putting out into the world
Right.
that everyone picked up on. I mean, he was kind of the first, he was such an early influencer,
Yeah.
right? But also, you know, lacked the protection
Right.
and and is now very protective of the
Right.
people who come after him, like Billie Eilish.
Yeah. Yeah. But and he's extraordinary talent.
Yeah.
Yeah, and has been able to negotiate it thus far successfully, and all that looks good for the future. So a great piece of advice. I think it's a great piece of advice for anybody kind of entering the world. The world, no matter wherever you are, no matter who we are, the world tells us who we should be,
Yeah.
right? And so they have all expectations of of who we should be in the world, and being able to figure out who you are and who you want to be, and then figuring out ways to negotiate that outcome is important.
I agree.
Yeah,
I agree. Most miserable developmental stage.
I would probably say adolescence.
Yeah. Middle school.
Yeah, I would say such a rough time. Really such a rough time. Hormonally, socially, forming an identity. Yeah. Getting your prefrontal cortex online.
Yeah.
Yeah. I think sort of like, I don't know, what do you think the best is?
I think early grown uphood,
Yeah.
where you're sort of free from parental support and you're kind of doing it on your own, figuring out your way and how you're going to make it in the world and navigate. So I would say that's generally like post college, right?
Yeah.
To where you're sort of flung out there into the real world and expected to swim. It's both a scary time and a joyful time, but it's a time of tremendous growth.
Yeah.
So I guess that's for most people 22 to 25.
I know. I think 50s to 60s.
You do?
Yeah.
Okay. That is great to hear, Paul.
Yeah. I just think that, like the noise quiets.
Yeah.
You don't have to prove as much anymore. You really could be able to focus on what's important and what's valuable. And, it's just, everything just kind of quiets down and you can focus. Yeah. And you still have your health and if you're active, and, you can, yeah.
Longevity is a whole thing.
Yeah. It's all of it.
That,
Yeah.
but yeah, and that's a great thought. It makes me happy to hear you say it.
Yeah.
So I think whenever we talk about wealth, we talk about generosity. And I just want to thank you for your kindness and generosity and sharing all that you know with people who want to learn. You captivated so many clinicians this morning, and your book is such I always tell young clinicians who want to enter this field, like it's the training manual of what you need to know to work with this population. It's sort of the onboarding tool for you shouldn't sit in front of somebody in this minority group without reading your book. I think your book is do not pass go unless you read Paul's book.
Well, thank you.
Thank you.
Thank you. It's been a pleasure to be here and spend time with you.
Yeah. We'll have to do it again soon.
Please.
Okay.